So how's it going?
I am ready to talk about ADHD today.
I am. Yeah, hopefully we can stay on topic. And so,
our track record is not great for that.
but it's okay. So, how was your week last week?
My week last week, I went to Colorado for the first time in living memory. The last time I was there was one, I think. And I remembered that I have weak ankles and that I am not good at hiking and I'm afraid of heights. But it was good. It was a bachelorette
the perfect
party.
triad for Colorado. Oh, it was a bachelor party.
Yeah. But it was beautiful. And it was great exposure therapy for me to work on my fear of heights and my fear of my weak ankles.
So were they having you hike for this bachelorette party?
It was like supposed to be like it was like a walk. I think it was supposed to be a walk. I made it to the little waterfall. But it was challenging I think I have Ehlers-Danlos. And so I really truly have the weakest ankles in the world. And I twisted my ankle twice walking down. So people are like, don't worry, just like walk faster. Like you're just afraid you're going to fall, but there's no way you're going to fall. I'm like quite sure I could fall. I'm very clumsy.
Yeah. You're like, there is a very realistic possibility in this case.
Yeah.
Yeah, and everyone else is like, all you have to fear is fear itself. And you're like, no, a fracture is actually on the docket here.
I have a fear of the side of the mountain. It wasn't even a mountain. It was literally like a hill and a creek. But it was very, very fun. And it was, whenever there's a bachelorette party, there's always like, this may be true for bachelor parties. I don't know. There's always like are we going to gel as a group? Because it's like people from different parts of their life. Like, what is the vibe
someone from each season of the bride's life.
And it gelled great, I think. One of my top bachelorette parties in terms of like, I feel like everyone had a similar sense of humor. So it was like very, very fun.
Yeah, I think with guys it's pretty easy. If you're like a season 3 friend and you meet a season 1 friend, you're like, oh, what's up, dude? I'm like, I'm college. And they're like, I'm high school. And then you're like, cool.
But what do you
and that's
do? Like, what about when there's like quiet times on bachelor parties? Like, because that's like, I feel where the bachelorette parties, like if they're going to bond, they bond super
watch
well.
Sports or something.
But like, you don't talk about how you all know the guy and are like, here's my favorite memory with him. And like, here's why I love him so much.
It just turns into a guy hangout.
Have you been a groomsman?
I have, yeah.
And what's our count at?
1.
Okay. Well, that's probably more normal.
So 1 out of 27. So I had a different weekend. I went to Austin City Limits, and it was incredibly hot. And
how hot was it?
I think it was 99.
It's like 199 degrees.
Yeah. It was funny. So when I went to the concert, I was like, oh, I have this small Osprey backpack and I'll be fine. Because I figured, they're going to search my bag, and they're like, no, like fanny pack or like clear. And so I had to go hide my backpack in the woods by the river in Austin.
Were the woods just there?
The woods are just there. Yeah. Because it's in the city limits. So I go and hide my backpack, and then I shoved my pockets with candy bracelets because I was like, oh, these will be fun. And then they made me empty my pockets out. And they're like, yeah, dude, you can't take anything with you that's food related.
What about my candy bracelets?
They were in the trash.
My gumdrop buttons.
Yeah, and then Chapel came on. She was really good.
What was your favorite song?
The crowd was packed. I mean, I like Red Wine Supernova or Pink Pony Club, which I think are the basic ones. And
what's she close with?
Pink Pony Club. I respect it though, because she's been having all this controversy in the media and about like taking a political side. She came out, she didn't talk, she was straight to business. She's like, I'm going to open with my song. And then she would finish the song. She would like go down to her Hydro Flask, just chug it for like 30 seconds, and then get back up and sing the next song. And then the very end of Pink Pony Club, she was like, bye. She literally just said bye, and she ran off the stage. I was like, honestly, that's someone who like clocks in and clocks out. But it was such a great performance. Like I didn't need anything else. I was like, honestly, like, look at this transaction. She wanted something. Like, she was there to perform her job, and I purchased a ticket, and we both came away satisfied.
I feel like I wish someone would model those boundaries in like working in healthcare. Like, can you imagine someone who's like, I'm gonna do a really great job, and when I'm not on call and when I'm not here, I'm not looking at Epic. I'm not chart tracking in the middle of the night. not ruminating about my patients.
Can you imagine doing that in therapy? You're like talk to them. You're like, okay, great session. Then you literally run out the room.
You're like, bye. Yeah.
Do you feel better?
Well, I feel like I don't like. I mean, you do do that in therapy though.
Yeah, a bit. I guess sometimes if time's up, you're like, okay, this is kind of a weird spot. We got to end it.
Yeah, but I feel like, see, this is our differences though as therapists, because I'm pretty psychodynamic. So it's like psychodynamic, or I feel like either way, I'm like, I need to keep the frame. Like I need to keep the frame of this is the time when we talk and this is how we do it. And if we end in the middle of a weird place, then when we come back the next time, I mean, there's also that classic thing of like ending in a weird place in a therapy session and being like, you don't really talk about the thing that maybe needs to be talked about for the whole session until the last 5 minutes. Mm-hmm. Are you familiar with the concept of like door handling?
Yeah.
Or door knobbing?
That happens to me. I tend to blame myself when that happens.
Nice.
Which we can reflect on in a different episode.
We can come back to at another time. Yeah.
So pivoting the topics, we're going to discuss ADHD today.
We sure are.
And I think it's especially relevant because it's been one of those disorders that has managed to take center stage, I think.
Yeah.
Or at least it has good press, I think, at this time in 2024. I saw you hesitated a little bit when I said that.
I feel like, so I guess one thing for people listening to this podcast that we've talked about, but concretely, if you're not in psychiatry residency, Preston is in his 2nd year of residency and I'm in my 4th year. And for most psychiatry residencies, you have a little bit of outpatient 2nd year, and then most of your outpatient is 3rd year. And what that means is that Preston and I have different kind of clinical experiences. And so I think that I would have said yes to that. Like, I think I agree with you that there's like more of an openness and less stigma on it than there once was. And like, especially like compared to a decade or, longer ago than that. But I feel like there can be stigma now in the outpatient world because like people, I don't know. I don't know that doctors always know what to do when people come in with like a self-diagnosis, which we will get into. But so I feel like it's sort of, it is and it is not controversial in a new way.
Yeah, it's happened upon new controversies.
Yeah. But I agree with you that people are more open to like receiving the diagnosis and it's not as negative or like stigmatized.
Yeah. So when we come back, we will go over a quick overview of ADHD, kind of like learn about the history of it, even understand that it has some neuroanatomical connections. And then we'll go into the TikTokification of ADHD and kind of see how do we get to this point where we're at today.
And then we will also talk a little bit about things that can be helpful for it outside of the meds, which we'll touch on briefly. And also things that are helpful from our view as people who are learning how to be psychiatrists, of how to learn about the diagnosis process and also what TikTok can offer maybe in terms of helping people with ADHD.
Mm-hmm. Because it's easy to view TikTok as only good or only bad.
Right.
So I have before me a bit of a timeline of ADHD. And so, Margaret, are you familiar with any of the history of ADHD?
I feel like little like bits and bobs of it, but like not the overall picture. So I'm also curious to learn.
Okay. So for anyone who's listening and has a passion about this, I know that some people reported back in the 1700s and 1800s. We're going to start our story at 1930 or in the 1930s. So I want you to take yourself back to Rhode Island, where Charles Bradley is a psychiatrist, and he's taking care of these kids in a home where he's handling people who are behaviorally challenged. So you have your classic like 1930s misbehaving child. And so this is the 1930s. So we're like, what treatment should we give to someone for anything? How about a stimulant? So Benzedrine was actually one of the main medications that we were giving for a lot of different reasons. If you look up old advertisements of like Excedrin and Benzedrine, they were talking about pilots that should use it so they could stay awake longer. We're in this period between World War I and World War II. They were advertising it to women for weight loss because it could suppress their appetite. And Charles was interested in giving it to these kids initially for headaches. And I've also seen accounts that it was for like a URIs or head colds. And it kind of makes sense, right?
Yeah,
like if, let's say you had a headache, nasal congestion, you're feeling kind of down. If I took a stimulant,
right,
it's going to put some pep in my step. I'm going to wake up a little bit.
Yeah.
Maybe the nasal congestion is going to improve because stimulants increase norepinephrine, which is going to constrict the vasculature in your nose. So it's like Afrin, basically. I mean, a milder version of it. So like, wow, like turns out we're curing the cold, you know? But then he discovered something really weird, which was when these kids took this medication, they started performing better in school.
Mm. Wait, so why was he giving them the medication?
Because he was just helping them out with their headaches or their colds.
Oh, I see.
So this kid, he just happens to be a misbehavior. And he comes to Charles for a head cold, gets a stimulant, and then goes back to school and starts performing better. And everyone's like, this is kind of weird because I thought these were morally bankrupt children. Why? Why are they all of a sudden like interested in academia now that we give them this medication? And he talks about how they developed this drive to accomplish things. They like wanted to get stuff done. And that actually of the children that had this Benzedrine, they tempered their emotional responses. So I think what he's commenting on is like their outbursts or their disruptions decreased. So I think we would interpret that as they were able to apply judgment better. So it's really interesting.
Dysregulation was less notable.
Yeah, so he did a lot of experience between 1937 and 1941. And it's fascinating because everybody likes to think of lithium as the first psychotropic medication that we really used in the early 40s. But if you want to make a case, Benzedrine was treating ADHD 4 years earlier in 1937 in Rhode Island. So in a lot of ways, ADHD is one of the oldest applications of psychiatry.
Yeah. And it's interesting, and I'm sure that you happened upon this, like in this case, that it's always interesting to hear the kind of old descriptions of psychopathology that would use like some words we still use today and some words we don't. And I'm sure with these kids. So what happened from there? Like, did he continue? You said till like 1941, which is an auspicious year. What did he continue to work?
Yeah.
World War II's impact on psychiatry cannot be appreciated. I'm realizing.
So there's kind of just like a huge pause on a lot of stuff there. And it's funny. So I went to the Air Force Academy, and it was a similar thing where the academy was supposed to be started right after World War I, 1949, 1950. And then the Korean War happened. So everything got delayed. And the university didn't open until 1954. And I think with a lot of advancements in medicine, a similar thing happened where they're like, oh, darn it.
Yeah.
If only there wasn't another nation trying to take over the world.
Yeah. I know, it's interesting. The primary one thing I'm thinking about also is like PTSD and shell shock, but we will come back to that in a different episode.
Yeah. So I guess going forward through the history, in 1944, Ritalin was first synthesized. And so that's methylphenidate is generic. It was actually made to help with blood pressure. So it was a chemist that made it for his wife, Rita, who she would get orthostatic while she was playing tennis. So he created this stimulant that he was like, oh, this is going to have a lot of like alpha-1 adrenergic activity. It'll help her blood pressure stay up. And it's for Rita, so it's Ritalin, not Ritalin, but we're Americans, so we turn our T's into D's. And it turned out
what a fun fact.
Yeah, it was way more effective for treating the symptoms of ADHD.
I bet she was locked in on that tennis game, though.
Yeah, so shout out to Rita. Yeah.
Rita.
So then to kind of fast forward through into the 70s now, there was a lot of concern about ADD being something that was overdiagnosed, which is, it was fascinating for me to look back and see that this is something that isn't new.
Yeah.
So in the 70s, there was this estimate that somewhere between 5 to 10% of kids in elementary school were receiving a stimulant for behavior disruption.
Okay. Yeah.
And people were like, it's being overdiagnosed.
Which is interesting because those
statistics are actually kind of
studies,
similar today.
Yeah.
And it actually makes me think of, you ever see those news articles where they're like, nobody wants to work anymore? Is this generation the lazy one?
Yeah.
And then you can go back and find it in the 1960s.
Yeah.
You go back and find it in 1890. And then they go all the way back until there's like an Egyptian stone tablet where like some pharaoh's written like, this generation doesn't want to work anymore.
Yeah.
It's just the same story, just retold over and over again. People act like they're coming on it for the first time ever.
Forth.
Yeah.
Yeah.
So during this period, ADHD has had this evolution of a lot of different names, and a lot of it has to do with how it's perceived by people. So it's been called hyperkinetic disorder. Minimal brain dysfunction is one of my favorite ones.
Brutal.
Yeah. And so I think that came from its correlation with autism and other things. People were kind of trying to clump a lot of these neurodevelopmental disorders into one bucket. And they're like, it's not totally
I can't believe it was
thing.
Basically like small brain disorder, like little brain
minimal
disease.
Brain dysfunction. Yeah. And it's like, it's a stupid name, because isn't everything brain dysfunction at some point? Like every psychiatric illness is to some extent brain dysfunction.
Yeah.
So, okay. Great job, guys. So then it was in the DSM-3, it was ADD, attention deficit disorder, which you see a lot of older attendees use. And then finally we adopted ADHD, so hyperactivity, as a part of it today.
Yeah. And at what point did we start thinking about, I don't know if we want to jump to that. I was thinking, at what point did we start thinking about the sort of inattentive or the misnomer that is even ADHD, which is, again, as you said, attention deficit disorder, and how we think about, we still call it now, that's still a DSM-5 diagnosis, but now I think we have a different understanding of what the attentional problem is. Maybe not as clearly a deficit as we originally, but certainly a better name than minimal brain disorder.
And it's been helpful that we're able to use fMRI studies and some neuroscience to take an examination of the brain where we couldn't before. We were just kind of looking at this black box and making assumptions about behavior. I think one thing that's always going to follow ADHD is this assumption that it's a lack of a moral compass, or it's a lack of willingness to do something. Because even hyperactivity, which can lead, and impulsivity, which can manifest as poor judgment or inability to sustain focus, is perceived as like a lack of interest or like a lack of care towards something.
Right.
So I think that even with this kind of new understanding that comes out, people will still have that perception that ADHD is not real.
Yeah, that it's somehow a choice to be under the ADHD or not.
It's volition. And I think there are cases where it is the decision of someone to not pay attention, not wanting to do things. And the reason why we even discover this illness in the first place is because the kids that behaved poorly started behaving well when we treated their headaches with a stimulant. And it shows that there actually was a gap between what these kids were trying to do and what they were accomplishing. And that gap was closed with the medication.
Yeah. No, I think ADHD is one of our diagnoses that, even as stigma is, hopefully somewhat reducing as people talk about it more, it's still like, philosophically kind of difficult. Like it's because in psychiatry, we still don't, even as we have like more fMRI data and things like that, we don't have like a diagnostic blood test or image that's like, okay, you definitely have this and someone else doesn't. And no one can know your internal sensation of things. So no one can know if it's costing you 100% of your day-to-day energy just to get to school if you're a kid, or if it's like, no, I could actually do it and it doesn't cost me much. No one can, we can't measure that.
Yeah. We're not the ones who draw the line for disorder.
Yeah. Well, we are somewhat, but like, we can't know. Like, we can't measure that distress necessarily.
Yeah. Getting into the neuroanatomy of ADHD, to start out with, we don't know a lot about it. And so a lot of these are kind of brain studies done in mice or fMRI studies with pretty low censuses. So a lot of it is kind of hypotheses and guessing. So and I'm saying that to caveat this because there's a reason why we can't just put someone in an fMRI and know whether or not they have a psychiatric illness. So as far as what contributes to the pathogenesis of ADHD, all we really know is something cytokines is the best thing I'm going to say. So it has a lot of the neuronal pruning that occurs in utero is mediated by immune cells. And there are a lot of steroid hormone receptors on the insular cortex and on the ventral medial prefrontal cortex area. So what they found is that there are correlations between higher oxidative markers and higher inflammatory cytokines, and they can actually have a linear relationship between the severity of ADHD symptoms in children and the presence of these cytokines. But like that's like the most non-specific thing you can ever find.
Right. So, and like, how do you, like, is it genetic? Is it environmental?
Correct. And so all we know is that if you try to look in the black box, something to do with hormones, or something to do with immune system regulation. And if you look outside the black box, we see severity symptoms. And then the other thing, the input, we see that people from lower income areas, people that had mothers with higher age, or like higher maternal age, exposure to cigarettes, poor air quality index, things like that, all increase the risk of ADHD, but we're not sure why. We can guess that it's related to this immune dysfunction. The other thing that we know is that there is a correlation between things like autoimmune disorders like asthma and eczema and ADHD. So when we do transsectional studies of patients that, let's say, use albuterol or inhalers, the likelihood of them using a stimulant or having ADHD is much higher. But we also don't exactly know why.
Yeah.
So the hypothesis right now is that there's something with T cell dysregulation that leads to impaired pruning of these centers in the ventral medial prefrontal cortex and in that striatum or posterior cingulate area. And the reason why that's relevant is because this is connected to one thing that we call the frontal striatal network, which is exactly what it sounds like. Your prefrontal cortex here, and it connects to your striatum, which is kind of like, if you think about your forebrain, it just sits right in the middle. It's like a little hook there. And without getting too much in the details of it, the frontal striatal cortex helps you with triaging goals and following through on tasks.
So executive function
is pretty intuitive for like why that could be a problem.
Yeah.
The other thing we see is that the ventral medial prefrontal cortex has a lot of implications in goal-directed behavior, emotional regulation or responses to things, like rejection hypersensitivity. And then it has to do with, or plays a role in initiating sustaining attention. So that kind of brings me into my next point. One thing that you're mentioning, which is we use these big words like attention, and then no one really knows what it means.
Right. Yeah. Well, and I think one of the things that this gets at is one, what you said of like, what do we mean by attention, but also kind of the overlay of both comorbidity and like the differential diagnosis for ADHD. So when we talk about attention, I feel like the thing that I thought about before, especially before I had like an attending who talked a lot about ADHD and sort of specialized in it, was a very broad sort of like, oh, you can, there's like the clinical examples that you think about in the ADHD like questionnaires and things like that of like for kids, like paying attention in class or being able to sort of regulate emotions or like being messy or organized in terms of the executive dysfunction. But when we think about attention, there are these kind of components that get broken down. And I think sometimes they're also hard to delineate from like, how do you differentiate like working memory and attention from like alertness or fatigue? And I think that all plays into the complexity of diagnosing clinically ADHD in addition to the like resistance sometimes people have to it. But I'm curious what you think about when you think of like a definition of attention.
So it's interesting you should say that. I'm working with a behavioral neurologist right now, and I brought that up. And they were like, here's this wonderful paper on why we're all passionate about how attention is such a crap definition.
Yeah.
And it kind of delineates what they call the taxonomy of how to describe attention.
Which paper is this?
And so I'll see if I can find it and send it to you. I don't have it with me right now, but the thesis of the paper was essentially that there's two big branches of attention, which are external attention and internal attention, and usually I would say stimuli from external sources or stimuli from internal sources. So external attention is if I recognize something in my environment, how do I shift my gaze towards that thing or pay attention to it? And it has to do with a lot of different things, like how do I filter out what stimuli I even pay attention to? And then now that I've filtered out the stimuli, because my eyes can perceive a million things. My nose can perceive a million smells. I can listen to a bunch of different things.
Mindfulness.
I have to triage what's important and what's not important.
Right.
And then I assign emotional values to those senses as I triage them. And then I make a decision about what I want to do in regard to that. So a lot of that has to do with the salience network. And that has more implications in schizophrenia than it does in ADHD. So we won't cover that now. ADHD has a lot to do with internal sources of attention, which is if I have an idea for something that I want to do, because right now I'm sitting here at this podcast and I could do a million things. Like there is an infinite amount of tasks Preston could accomplish technically, but I have to be thinking about which ones are deserving of my attention. And I triage that importance.
Right.
So that is the type of attention I think about it almost like a laser pointer. But I have this internal laser pointer, I'm trying to point it at things. So within that, it's divided into, can I sustain it on one object for a long period of time? And then how do I prioritize what deserves my attention?
Right.
So that kind of goal-directed behavior is the frontal striatal network that we were talking about earlier, which we know has a lot of impairment in ADHD.
Right.
So I think it's important to like help people understand that it's even a small subset of their attention that's affected. And if you have something like anxiety and you're hyper aware of stuff in your environment, and that's impairing your attention, it's not necessarily an issue with your ability to point the laser pointer somewhere. It's that your threshold to pick something up and the noise in your environment is just so low.
Right. But to complicate that, right? Like actually being able to pinpoint that as like an individual or as an individual and a doctor dyad or, relationship, I think is quite hard because like, is it that you're anxious because you're in sort of like an overstimulating environment, or is it that you internally react to that secondarily with like a strong like thought pattern or internal stimulus? But yes, this like regulation of attention is as the difficulty, and also that's not just present in ADHD in some ways. So there's like quite a bit of overlap.
Yeah, and both can be present. Like ADHD and anxiety are comorbid.
Super comorbid.
So it's always been really challenging for me to discuss someone's attention when they come in and say like, hey, I'm having trouble focusing.
Right.
It's really a vague differential. And to try to say like, okay, I usually start with, is the problem starting a task or is it staying on task? And I'm curious how you kind of attribute this, but I think about procrastination as mostly an emotional process. A lot of our reluctance to start a task is more so like how we feel about the task. But once you're starting on the task, that is your ability to sustain focus.
Yeah. I think though that like, if we think about learning how to do life with like an ADHD brain, again, it kind of stirs those two things together. I think I maybe more orient myself towards like domains of people's life and then like where they're noticing it and like what is, the regular kind of diagnostic stuff for ADHD in terms of using the different kind of like set of forms and like childhood and adult observer forms. But I think what you're getting at too is that there's different ways that lack of attention regulation plays out, and like how do we delineate those? I mean, I think when someone has an ADHD question and they're like focus, concentration, being able to complete things, disorganization, when they come in and they say that to me, I tend to be possibly annoyingly thorough. And so I have them do like all of the things that can impact, like I have them do all of the forms that evaluate ADHD as well as ones looking at anxiety, depression, and for some patients like PTSD in terms of like the sort of like ability to respond to an environment and have attention be focused and then enact a task.
Yeah. And so I think kind of the questions I'm asking may be like one of the lines off of something like the Brown ADHD questionnaire, which I've always found these like to be interesting. So I pulled it up. It's when you have to do a task that requires a lot of thought, how can you avoid or delay getting it started? So I think that's a great example of someone who maybe has had a lot of trouble staying on task their whole life. So then they have learned to associate those tasks with negative emotions.
Right.
And now they have a reluctance to start anything. So maybe I'm emotionally have a bad relationship with reading because I've always been bad at it. And so while like my ability to sustain attention isn't the reason why I'm not starting reading, it's actually a consequence of my inability prior in my life to hold my attention.
Right.
So this is like evidence of someone who's developed essentially a poor relationship with tasks that they have to sustain their attention with.
Well, I think that's also one of the things about, more broadly, this kind of question of the adult ADHD diagnosis outside of like what we see online or what doctors say that's good or bad, is that there is a lot of missed diagnoses likely in ADHD. And when we miss it and we don't get medication or therapy until into adulthood, kind of how does that change how we think about it for ourselves? 'Cause I think a lot of like, sometimes there's some like patients I've had who came into my like younger clinic that were like in their late teen years. And so weren't necessarily, they were somewhat late diagnosis. But if someone comes in their like 30s and they've had to live their whole life with this ADHD symptomology and maybe they've coped with it, but like, how does that impact, I think what you just lined out, the like behaviors they have, but also how does it impact their vision of their self and their vision of themselves and like how because they have at that point 30 years of learning
that this is who I am. It's like a part of my personality.
Right.
And so maybe they've come to the conclusion, I'm just not someone who likes reading.
Right.
It's just who I am. Whereas maybe they do have a curiosity for like books and stories and things like that. They've just kind of taught themselves to hate it. Where it's really interesting for me to see kids that get treated early and they have, I think, a healthier relationship with their idea of the disorder because starting at age 6, they've been able to see themselves on and off of medication. And so maybe if that person doesn't like reading, they're like, oh, when I don't take my meds, reading is hard for me. And that's the relationship they have with reading the rest of life. They haven't thought, hey, this is just a part of my temperament.
And at the worst is, and I definitely think people with ADHD, like it's still an invisible kind of disability, and the medications don't take you all the way there, but kind of this explanation of what we kind of started the episode with, or like what we talked about with the history of, I can't clean my room as a kid. And part of that is because I need to do it in a different way because I have ADHD and I have to do things a little differently versus I can't do this. And everyone around me is telling me I can't do it because I'm lazy and bad. I think in particular, thinking about who did not fit on the historic diagnosis in ADHD and also who is more likely to present for care. So in this,
it's anyone who's not a white male.
What?
Is essentially the answer, unfortunately.
Do you want to talk a little bit about why that is from your understanding?
So I think a lot of it just comes from our interpretation of behavior. So one thing we know is that minorities, specifically Black males, if they exhibit a lot of ADHD behaviors, they are more likely to be diagnosed with something like oppositional defiant disorder than their white counterparts. And while this has kind of been the theme of the episode, people interpret the symptoms of ADHD as moral dysfunction. So if you're in an environment where there's aspects of like systemic racism or a lot of implicit bias, someone's more likely to have to lack a generous interpretation of someone's misbehavior. And so it's in a lot of ways, you're trying to rule out other things that before you come to the conclusion, hey, this person is just disobedient. And so for like white kids, pull out all the stops. Like, we're going to go do this full neuropsych workup before we say that you're misbehaving because it has to be something else. Whereas maybe other kids, the teacher has already dismissed them as misbehaving from the start. And then they don't work up this ADHD diagnosis. Right.
Yeah. No, I think that is definitely one. I think from the perspective of like, why did little boys in the 90s get diagnosed versus little girls? And that's not true across the board, but was that the idea of ADD and then ADHD, and I think still is to some extent, is the kind of behaviorally disruptive, running around a mile a minute little boy with ADHD versus the inattentive subtype in both boys and girls is also, an attention regulation issue, but doesn't make them get in trouble. And I think particularly for little girls who are socialized to behave in a certain way as a girl, it means that ways of coping and dealing with attention dysregulation can remain hidden for longer because they're less disruptive.
Yeah. And so I believe a majority of kids are combined type. It's the most common one we see. But if someone has the inattentive subtype, so just a reminder, there's 3 subtypes of ADHD. There's primary hyperactive subtype, inattentive subtype, and then combined, which is just both. If someone is inattentive, they're more likely to be female. And if someone is hyperactive, they're more likely to be male. And in addition to what you said, the women that are socialized in the back of the classroom, they're just kind of seen as not paying attention. And you can slide through the cracks. But if someone is getting up and moving around and then they take this medication, they stop getting up and moving around, it's just that the radar we have to detect the changes of their behavior is just more sensitive than this girl in the back of the classroom, that if she took the medication, she would stay on task and maybe she wouldn't be perceived as stupid, which is the conclusion that was being drawn prior to that.
Right. And that there was more. I was reading, I don't know when the original copy of this came out, but it's the book Women with ADHD, and talking about the idea sort of that it was more acceptable. And maybe this is hopefully changing and not as true now, but like if a girl was underachieving and wasn't, getting really good, scores in her class, that there has been historically in school systems an emphasis on men are the one who should go to school and they're the ones who should do well. Again, hopefully that is changed even in the 90s compared to prior, but that this is like a legacy that also impacts how much little girls are pushed in terms of figuring out why they're not achieving at their maximum quote unquote potential.
Like if I'm not performing, it's consistent with my concept of self.
Right. Or if I'm a girl who can't do math, it's because girls can't do math, not because I have ADHD.
Right. And if I'm a guy and I'm struggling for any reason, bring out the psychologist.
Bring them out.
We're getting to the bottom of this. And unfortunately, it has a lot to do with socioeconomic status.
Yes.
And the even ability to have a parent advocate for you and suggest that it could be something. So I've had patients who they had parents who didn't believe in medication or didn't believe in ADHD, and they end up with a stimulant use disorder later in life. And I kind of ask them about their relationship with methamphetamine, and they'll say, it's really weird, but it's the only thing that helps me work on the job site. Yeah. Like I get up in the morning, I take a hit of methamphetamine, and then I go do construction, and like I'm a better boyfriend. Like I remember stuff with my girlfriend. I execute things at work. Like I function in my job. He's like, I don't know how to explain it, but it's like taking a cup of coffee times a million, and I function well with it. And it sucks because this is someone who I think could have definitely benefited from a stimulant earlier in their life. And now they're self-medicating with an illicit substance, which has a lot more risks. And on top of that, they've been labeled someone with a stimulant use disorder.
Right. So it's going to be harder for them
means
to
they'll never actually be able to treat this disorder.
Yeah. I mean, I wouldn't say never.
Yeah, but like, I guess dramatic, but
one of the
common for people to say like, I'll never give you a stimulant because you have this history of methamphetamine use.
One of the papers I was reading for this episode it's from BMC Psychiatry, and it's Adult ADHD and Comorbid Disorders, Clinical Implications. It's from 2017. But one of the things that I think I've learned before, but was just interesting to read about, was kind of the impact on studies of kids on stimulants at like entrance of adolescence and kind of like quality of life and sort of like achievement attainment. And that in kids who had gotten stimulant, like been diagnosed and gotten stimulants, and kids who hadn't. And certainly there's like co-variables with that in terms of who has access to treatment, but just that kids who got stimulants and their level of achievement in adolescence and like in their 20s and 30s was very different, including a much reduced likelihood of substance use disorders.
Yeah, I think I've actually seen that paper too. It's really fascinating.
Yeah. And so there's this thing of like the comorbidity of substance use disorders and people with a diagnosis of ADHD, and kind of a chicken and egg, where people will kind of talk about it as, I think sometimes as like the impulsivity part of ADHD, but it's also like a self-medicating component, and that having kids on stimulants or having people take the gold standard medication for ADHD at whatever point is, rather than be this risk for substance use disorder or addiction, is actually likely
it's the opposite.
The opposite.
It decreases the risk of it. And not even for just substance uses, but the impulsivity, or maybe this is another chicken and egg situation, with the engagement in like dangerous activities and accidents. So as we know, for adolescents, 21 through 30, I believe, the number one, if not one of the top causes of death is accidents. And so people that are engaging in these risky activities who may be impulsive, and also maybe they get some kind of sympathetic high from whatever they're doing, and it's kind of taught them, oh, like this is a reward pathway for me.
Mm-hmm.
Those accidents are also have the benefit to be reduced. And I think I don't want to be misquoted as well, but there is another study that looks at mortality benefit of stimulants started early in adulthood, and looking at kind of just like you described. Maybe we don't know exactly why, but if you're less likely to develop a substance use disorder or engage in these dangerous activities,
mm-hmm.
you are intuitively less likely to die.
Right. I mean, I think one of the populations that I work with is the perinatal psychiatric population. And this question of like actually really thinking, like being thoughtful about the benefits of a stimulant versus like the risk of taking a stimulant while pregnant and the concerns for the fetus on growth restriction and some other parts, is a really difficult conversation. And often I'm the one not necessarily like pushing for the stimulant to be used during it, but talking about things like, when you weren't on a stimulant, how many car accidents did you get in? Like how much function was added to your life, and like, what you're talking about of,
did you remember to eat?
Yeah. Like,
did you remember to bathe?
Right. Because we know that not treating mental health concerns in pregnancy, not treating it, it's not like you either have this exposure to a medication or it's nothing. It's unmedicated ADHD, unmedicated depression, bipolar, whatever. And the risk of that on fetal outcomes, not to mention maternal outcomes, versus the risks of the medication. So
yeah, I think it's helpful to view it as it's always an exposure. I'm either exposed to the medication or I'm exposed to untreated ADHD.
Yeah, exactly.
Like I'm exposed to lithium or I'm exposed to untreated bipolar.
Right.
Having a manic episode is terrible for a child. Mm-hmm. So we're going to weigh the risk of relapse against the risk of lithium in pregnancy.
Right. Yeah.
So now that we've kind of ventured through all the clinical science of ADHD, we also have this other aspect of it, which is how it's used in social media. And I think this is unique for you and I because we're both content creators on TikTok, maybe a little bit chronically online, and have been exposed to the TikTok world and ADHD as I think a lead character, I would say, for at least my For You page for the last 4 years or so. So when we come back, we'll kind of talk about how we see TikTok and ADHD, and then also, is it useful? Mm-hmm. We know there's a lot of misinformation out there, but is it all misinformation? And how do we kind of sparse that out? I remember the first time I saw ADHD related TikTok. I think it was they were filming themselves in their house and they were like 5 signs you might have ADHD, and they're playing
Did they dance and point at things?
Yeah, they got like funk music in the background, and all of the things they highlighted were extremely relatable to I think anyone who's a human being. I think one of them was like, if you hate going to school in the morning,
ADHD.
Or it was like you have trouble maintaining relationships, ADHD. Yeah. You don't like doing your laundry. Or I think it was like you have laundry piled all over your room. And I like to think it was well intended and like it's cute to say like, yes, these are all things that people with ADHD can experience. But then the implied logic is if I experience these things, therefore I have ADHD.
Right.
And it's kind of like saying like, I don't know, if I have malaria and I experience a fever, and then I go up and say signs you might have malaria, and it's like your temperature is over 99, and then it's like, oh my God, it's malaria. And we're like, do you know how many things can cause a fever, please?
Right.
And they're like, you're right. Brucellosis. I know exactly what I have.
Back.
Yeah.
I think it's also, I feel like the same phenomenon I feel like I first started noticing on actually like Instagram before the pandemic with like people talking about like trauma. But it was like here are 5 signs of like things that are normal day-to-day struggles. Similarly with the ADHD stuff of like 5 signs you might be acting out in a trauma bond, or like, here are 3 things traumatized people don't do. And it was I think similar with every diagnosis, like a diagnosis can be something that helps like open up your world or closes it down. And we don't want to pathologize the human experience because it often can make it harder, not easier to cope with.
Mm-hmm. Yeah, exactly. So fascinatingly, they did a study in the Canadian Journal of Psychiatry on the accuracy of these TikTok videos that we were seeing. Mm-hmm. So this is called TikTok and Attention Deficit Hyperactivity Disorder, a cross-sectional study of social media content quality. And so essentially what they did is they looked at 100 different videos, 100 of the most popular videos, I believe, with the hashtag ADHD, or they're classified somehow as being ADHD related. And then they assessed them with criteria for if they were misleading or if they had factual information. And what they found is that about 27% were classified as misleading. Around 21% were classified as personal experience, and or somewhere in the middle. So around half of them together, so 27% plus the 21%, were not like medically factual information. When we're just like personal anecdote that were being shared as facts. And that I think another interesting thing is that some of these non-factual videos were posted by healthcare providers.
Interesting.
So I think there is another tendency that I see too on social media, which is that somebody has the title healthcare doctor so-and-so, and then they feel empowered to talk about anything in medicine. And I don't know if you've seen this, but I've seen plastic surgeons or dermatologists happily weigh in on schizophrenia and ADHD. And I'm just kind of like, what? You know, like why do you feel like kind of comfortable like sharing your 2 cents on this?
Yeah. My For You page is a very different world, I think, than yours. But I
think I'm probably deeper in the med talk
TikTok,
than you are. Yeah. It's just like fascinating to me. And I think some of them, maybe they see themselves as they make medical content related to anything, but then it kind of can lead to this complacency about talking about stuff that's like not really in their lane. And I think I have a hesitancy to that. And it's funny because I know other people feel similarly. Like I was an intern on medicine. So I've been on the wards for like 2 months. And so I feel like I was getting pretty good at sliding scale insulin. So I wanted to make a video about sliding scale insulin. Just kind of like how I approached it. And I got like a decent amount of clapback that was like, you're a psychiatrist, stay in your lane. Like don't talk about internal medicine stuff.
Yeah.
And I was like, honestly, like kind of fair. Like all I have is this 2 months of experience in my internship that I'm trying to parse along. And I think the same goes to these other clinicians who essentially have the training of a 3rd-year medical student in psychiatry. And now after they've finished their 6-year fellowship in something else, are coming back and then sharing their opinions on a mental health disorder.
Well, I think you know this from our conversations offline, that as a trainee, as someone who I'm applying a fellowship, but as someone who could be a psychiatrist basically in 6 months and be done, I have a lot of kind of, I think, imposter syndrome, but also real respect for the complexity of our field to even do this podcast with you, as we've been working through together for me. And so I think the other part of this for me, and where I see it come up a lot, is like, even if you give factual information, it's given in a vacuum that is like non-contextual. So even when there are psychiatrists, and like, we've only done a few episodes at this point, like there are so many lenses or so many kind of views you could put on perspectives of what a psychiatric symptom means, that all have a lot of validity, but also that there's like fair disagreement. And so I think one of the issues is just like, how do people apply general psychoeducation online, and how do we communicate it in a way that is helpful without being almost prescriptive inappropriately?
Yeah, and I think maybe until further notice, my solution to that is you just can't do it. And I think like we can have these conversations about ADHD here, and I think even right now we've been talking for almost 40 minutes, and we're taking a small lens of it. We're not scratching the surface in the way that we could. I think if you take a video and list a bunch of transdiagnostic symptoms, imply they're exclusive to ADHD, and post it online, I think it ultimately does more harm than good.
Right.
Because it leads people to come to this conclusion that maybe they have ADHD, and then it leads people that don't have ADHD to kind of view it almost as this like kind of cartoonish, sensationalized phenomenon, which I think is unhelpful to, I think, our relationship with mental health disorders as a society.
Yeah,
I think reduction. I think it's an overcorrection. Like we have this drive to normalize mental illness, but wouldn't that mean to make it treated the way we treat other illnesses? Right. So, for example, I don't think I would put in my Instagram bio all of the like times I've had an upper respiratory infection or a UTI or something else, but we kind of interpret our mental illnesses almost like they're a badge or something to celebrate. And I think sometimes that changes how others perceive our relationship with our mental illness. Like, I think it's seen by the person that has it as like an ownership of their symptom. Like, this is something I've been stigmatized against, and now I'm taking my chance to own it again.
Which is valid. Yeah.
Yeah. Which is, I think it's a reasonable thing to want to do. And also taking it back and celebrating it isn't going towards normal.
Right. I think
you see what I'm
that
saying?
like, yeah, I get what you're saying. I think this is a super complicated topic in terms of, and even if you just zoom in on like the ADHD kind of community of, they'll be kind of, I don't know if controversy is the right term, because it's like in a subreddit, but like they'll be kind of like, okay, well, some people find it helpful to view the sort of increase in creativity or kind of divergent thinking that people with ADHD have as like a superpower. And some people say, this causes me so much pain, this illness causes me so much pain, how dare you like kind of silver line it. And I think similarly with this question of how do we ask people to own something that is both difficult and in some ways in it's at least something in who they are, right? Like with mental illness, making sense of who we are versus who the ADHD is and trying to actually parse those out is really, really, I don't know that there's one answer to it. So I say all of that to say, like, I think probably making like ADHD or any mental illness the entirety of who you are reduces who you are, but also that there's been so much to say to get people to try and hide their illnesses and their struggles that I understand the desire to kind of react to that and make it like, I'm okay with this. And if you're not okay with it, then like you can see that it's part of who I am.
Yeah. I think in a lot of ways it's the category that ADHD gets put into, or these other illnesses, is almost like gender or sexuality. And I think that's maybe where the pursuit of neurodivergence as like a label comes from. Because my sexuality, whether I'm heterosexual, homosexual, or transgender, cisgender, those aren't necessarily disorders. They're just pillars of my identity. And so they could argue that, oh, my ADHD is just another pillar of my identity, but it's not a disability. And I think there are some people that are even under the kind of the belief, like you said, that ADHD isn't a disability; it's a superpower, if anything.
Yeah,
and
I think this broadening of what the idea of
dangerous,
quote unquote, broadening the idea of what is normal or what is like natural, quote unquote, what's human, what exists in the human, world, just not because a set of things is good. I mean, and let's be real, like the DSM-5 is based on saying some things are quote unquote normal and some things are not because they're outside of sort of 2 standard deviations, even though that's also debatable. Yeah, I think this kind of idea of like a spectrum of symptoms, but that's also why in the DSM, it's always, is this getting in the way of the kind of life that you want to live, including with ADHD? Like, are you creative and that's it? Or is it like, I'm creative, but also my life is really, really hard because of this attentional disability?
Yeah. I think one analogy that is coming to mind is tic disorder. So I'm in adolescent clinic, and we are treating some patients that have tic disorder, and my attending's approach, which I agree with, is how much the tic affects them is really how much you guide treatment. So if somebody has a tic, like they just shrug their shoulder continuously, and you ask them if it bothers them, and they just say no, then the tic is just a quirk, really. But then if you took another person and put them in that brain, they said, yeah, this shoulder shrugging bothers me. So I want to stop it. Now it's a disorder. Now it's tic disorder.
Yeah. No, and I think I remember in med school, like some of my friends being like, I'm thinking like leaning towards like emergency medicine or other kind of like fast-paced specialties, because they were like, I can't do, like, they're like, I don't want to sit for an hour in a room like a psychiatrist would. Like, that's just not the way my brain works. And that would be kind of painful in some ways. Whereas like, I hate the emergency department. So, but like picking the space also with this idea of neurodivergence is like, like the cliche quote that everyone always says, like, if you judge a fish by how it climbs a tree, you're going to think it's like very dumb. But neurodivergence allows this kind of like that there are different places where people with an ADHD subtype brain thrive, and they just have been forced into situations that can't measure that their talent or their strengths.
And they're more adaptive in the emergency department would be the argument. Yeah. Or like in Percy Jackson, the Olympians.
I've read those. Yes.
Yeah. I think at some point he was diagnosed with ADHD. And then he shows up to Camp Half-Blood and they're like, actually, like your ADHD is just your demigod sense telling you like to be aware of things and like focus on stuff. So I think in that, like, it was
your gods.
ADHD was literally his superpower. He's like, you're half god. And like, that's what being ADHD is.
I love those books.
I guess like anything, you have these traits on a spectrum of inattention and these traits on a spectrum of impulsivity, impaired judgment. And whatever environment you're in is going to determine how adaptive those traits are. So I think there are some people that their traits are so extreme that they will have a gap between how they live their life and how they want to. So they will meet the definition of disorder just about every context. And I think there are other people that, depending on the context they're in, they may be perfectly adaptive and they'll function well. And in other contexts, like struggle a lot. So school is a place where you have a lot of demands on your attention and your judgment. So maybe you do have a disorder in that sense, but outside of school, people may function okay.
Right.
So like philosophically, do they have a disorder? It's like, well, in one of their environments, they do.
And what makes that person, like if I put someone who like thrives in the very structured, like modern school environment versus, I mean, like me, like hated the emergency fire, hate kind of like these like unstructured whatever environments. Like what makes us say the person with the ADHD brain is the abnormal one versus the person who can't thrive where the ADHD brain could?
Yeah. And I guess maybe that comes from our definition of disorder. So like,
we're not going, this is the dark history of psychiatry, which we'll talk about in another episode.
You have to say, like, I think there's this assumption that if there's a disorder, we're saying that there's pathology, and that pathology is because of some kind of failure or issue with the person involved. It's disease, and therefore, like, there's something wrong with you, which is the ultimate implication. And people want to say, like, there's nothing wrong with me. This is a normal reaction. You know, of course, a fish wouldn't like this. But I guess, like, we can still have disorder and quote unquote like pathology and normal reactions. So like the analogy I use all the time is like, if you get hit by a car or if you get burned or something, it's a normal, reasonable reaction for you to break your leg, but it's not your fault. And so I think just like how someone may have normal traits that when confined in this like rigid academic environment may manifest as disorder, doesn't mean there's anything wrong with them.
Right. And I think like this, to tie this into what we talked about a couple episodes ago, it's interesting how you could take someone who's like, especially in like the adult world, so not just the child world, but also this is true in the child world, someone who's like exhibiting ADHD symptoms and instead take it and look at an attachment lens and say, it's not attention, they don't feel safe. That's why they're doing this, and this. And this seems maybe somewhat tangential, but I think it's interesting to think about what we talked about a couple episodes ago and be like, we could frame like kind of the same clinical approach. And obviously we try to use all of these frames at once and integrate them, but just to get at that kind of contextual part of someone could take a different lens on ADHD, and people have to both help and hurt in the history of ADHD, and have a completely different set of recommendations than what we've talked about right now.
Mm-hmm.
I wonder, in kind of our last portion here, what do you think is helpful about the online world for people who are wondering if they have ADHD?
So I think one thing that it offers them is validation for problems they already have.
Mm-hmm.
So I think if someone is experiencing a lot of issues and then they seek out the online world and feel validated by that, that can be helpful.
Mm-hmm.
And I think there are a lot of people that do discuss ADHD with nuance.
Mm-hmm.
So what's really great about something like TikTok is that you have neuroscientists and psychiatrists who try to engage in these very like long and nuanced discussions or caveat well the information that they're giving. And it's amazing because essentially you get to have a FaceTime conversation with someone who's an expert in the field. Right. So while you have to filter out the memes of the disorder, though, you also get to see a world expert discuss it. So I think it's a double-edged sword. And as far as the solution to like knowing who's legit and who's not, it's hard. I would say just about every time look at someone's credentials. So there are people that will put doctor in the handle and then you look them up and they're a naturopath or they're a chiropractor and they really have no meaningful training in mental health at all.
Right. At least not by the definition that most people will correlate.
Yeah, not by our
with
mutually agreed upon
doctor,
like understanding of being a mental health provider within the United States. So
I think if anyone's trying to sell you something more than a book, be a little nervous. Be a little nervous. I kind of agree with you that like we know there's not, especially right, like one of the biggest shortages in psychiatry in terms of access to care is in child psychiatry. So like we're talking about like, oh, we should get people diagnosed. We should get them the care they need. We should this, that, and the other. And there's also a shortage for access for adult psychiatry and for the other portion that we didn't talk as much about, which is different forms of therapy and like executive function kind of oriented psychoeducation groups. There's also not a lot of access to those things either. So I think that the thing that online can offer when they're nuanced is access to information about, and like an ability to self-advocate, especially for folks who in the past have historically been underdiagnosed, that we've talked about a little bit. And that advocacy, though it sometimes I think annoys doctors, is not always a bad thing.
Yeah, and that like everything has to find balance. The other thing I would add is, and I think this is just a golden rule for finding a scam, is it to build upon if someone's going to sell you something, it's if somebody presents you with a problem that you didn't know you had, and then immediately happens to conveniently know the solution to that problem. And for some reason, it involves you being separated from your money.
Yeah, in a webinar.
Yeah, and it's sad because even though we say like look at credentials, like there are psychiatrists with like MDs that still will be kind of quacks in this regard.
Yeah,
and will be preaching stuff that's inconsistent with the general like scientific consensus. Like for example, I think there's this one psychiatrist who's talking about the carnivore diet, and he's like, actually, like all of our problems come from like us having too much oxalate from salads. So, like, stop eating vegetables. Like, what, dude? And so it sucks because people want to trust this person, and they look at them up and they're like, they have an MD. Right. But they're just spewing absolute nonsense.
Right. Well, and I think one of the things you and I can speak to, right, like we're in training to do this. It's really hard to interpret the data like alone. Not that there's not answers in it, but it's like there is a lot. And so, yeah, anytime there's like this is the one way and this is it and this is right and everyone else is trying to fool you.
And those are satisfying answers, unfortunately.
They are.
I have the answer.
Yeah. We have the answer on this podcast. There is no answer.
Yeah, exactly. So it's almost like the more unsatisfying the answer is, the closer to the truth you probably are.
Exactly. Yeah. Unfortunately, I always tell my patients like, hey, listen, I wish there was one answer. Like that would rule. I wouldn't have a job anymore. But honestly, that would be okay. Like if there was one answer, that would be amazing. Unfortunately for both of us, I don't think there is.
I know. Like they'll sit there and be like, I just feel like I don't have any purpose. And I'm like, I wish I could prescribe you something
I wish
that
I could
gives you a
prescribe
sense of purpose. Yeah. How easy would that be? You know, this is why you're drastically unsatisfied with your life. The only thing that stands between you and self-actualization is this
our
pill that I'm
online
about to prescribe you. Yeah.
Our online coaching Patreon behind the paywall.
Yeah, which is personalized.
Super
it's
personalized.
A personalized template. It's just like embarrassing. That even like as someone who's like attached to healthcare could be like ever associated with that type of advertising or business. It sucks.
It does suck.
And the same is so true for the fitness industry.
Mm-hmm.
And I guess what I see a lot there is that people have those like secret hacks or the satisfying answers. And the reality of a lot of fitness is that it's very simple, but that doesn't mean it's easy.
Right.
Like exercising and eating healthy are not mysteries, I guess. They're not scientific mysteries. We're aware that they work, but they're just extremely challenging. Yeah. And I think a lot of it is true with things within mental health. Like we know that having a sense of community, having a good sense of purpose, having
daily movement.
Yeah. Being in touch with your emotions are all like easy things to say on paper and hard like to unbelievably challenging to execute. Yeah.
And have access to. Yeah. I mean, I think the thing I would like to end with is talking about places that we like in terms of like learning from people either who have ADHD or from clinicians or just anyone who's kind of involved in this that we think are good places on TikTok, but also online in general. I think a classic that I recommend to my patients is the How to ADHD channel on YouTube, which has got a ton of great videos that are like also super helpful for learning skills that are parts of the like behavioral and executive functioning therapy that we use for ADHD. So she also has a book out that I have not yet read, but that channel is really, really helpful for a lot of people.
Mm-hmm. And then one that I thought was really fascinating is Priyanka at Little Miss ADHD on TikTok. So I believe she's a pharmacist and she has a lot of discourse about how like ADHD is sensationalized, and then she'll contrast that with how much it challenges her in her daily life. And I think kind of a lot of her narrative is actually around like, please stop making ADHD seem like it's this quirky, fun illness. It causes me a lot of turmoil. And I think she has this sobering retelling of a lot of her symptoms. And so I think for people, it can be very validating because they also experience the symptoms, but then it's also someone who's not trying to sell them something at the end of the day. They're really just trying to have this lucid, undoctored report of their experience.
Right. I do think that like, even though that one paper was talking about like what's anecdotal, I do think that people having stories, like one of the things that we know that helps people on inpatient units and in group therapy is hearing how other people cope with illness. And so I do think that's also something, and it sounds like this person does it well, it is hearing other people's real thoughts about how they cope with the symptoms or diagnosis that they're struggling with.
And I'd like to add, there's different values to anecdotes. So there's, I have ADHD and this is what my morning is like. And then there's, if you struggle to do laundry, you might have ADHD because I have ADHD and I struggle to do laundry.
Right.
So like using the anecdote as like proof or as like an assistance to help other people diagnose themselves may not be rational, but it's really validating for you to just say, hey, I have ADHD and let me tell you about my experiences.
Yes. Yeah, totally. Totally. So we will be talking about the carnivore diet in our next episode. Although I will say, as someone who has to take iron supplementation, eating steak did actually help my energy levels.
Oh, so yeah, maybe he's onto something.
Maybe he's onto something. The anemia girls get up.
And then I'm on the creatine diet as well.
So what's the creatine diet?
I take creatine.
Oh, I take that. Gotta get huge. Gotta get swole. When are we gonna do our exercise episode?
that will be a good one. We'll have to do it in the gym. So
We'll do a live episode at the gym.
Yeah, I think creatine would be a great one to cover. And then I'll be working on my bench press until then. So it'll be a good competition. Yeah. So my hope is that actually Priyanka will be able to come on the podcast and chat with us a little bit about like her experience as a content creator who discusses their mental illness so openly and has to navigate a lot of both the stigma and sensationalization of the illness.
Yeah. And it's also online and in the world that we're in.
Yeah. Yeah. And I think she kind of sits on the other side of the table from us as almost the role of a patient, and on the same side of the table as us as a content creator. So yeah, I'll be curious to hear her perspective. All right. Well, that's all I had for today.
Same.
Margaret, I am now going to end the podcast.
Okay. Very smooth.
I
concrete.
I just don't know how to do this without being robotic.
Maintaining the
Yeah.
frame.
Hey, hello. How was the show? You, the audience member, I have a couple questions for you. Did you like my voice? Do you like the jokes that I make? Please tell me that I'm cool.
Please like them.
No, but seriously, if you have any questions, please come chat with us. Talk to anyone on the Human Content Podcast family. We're on TikTok. We're on Instagram at Human Content Pods, or you can reach out to us we have a website too. howtobepatientpod.com. I always forget the pod part at the end, but it does exist. Otherwise the website is not real. And then also, like, we're dynamic. This is a new podcast. So if you guys want us to cover any topics, if you want us to dive into things, if there's things
you want the live Us the Gym episode.
Yeah. If there's stuff you hated, tell me.
Tell him and not me.
And I'll think about it.
I don't
yeah,
have
Margaret
strength.
will cry. And there's stuff you liked, I also won't tell Margaret. And I'll just
I need neither side of the coin.
So if you want to see full videos, you can look at my YouTube channel at It's Presro. And those are all the places you can find us. So thank you again for listening. We are your hosts, Preston Roche and Margaret Duncan. Our executive producers are me, Preston Roche, Will Flannery, Kristen Flannery, Aaron Corney, Rob Goldman, and Shanti Brooke. Our editor and engineer is Tracy Barnett. Our music is by Omer Benzvi. And you can check out our show notes to see references and resources we used in our discussions in this episode. To learn more about our program disclaimer and ethics policy, submission verification licensing terms, and our HIPAA release terms, go to the website, howtobepatientpod.com, or reach us at howtobepatient@human-content.com with any questions or concerns. Remember, How to Be Patient is a human content production. Thank you for watching. If you want to see more of us, or if you want to see, this is Lilac, she's my cat. She's going to be waving her hand at one of the floating boxes, which will lead to more episodes. Lilac, point to the other episodes. Lilac doesn't know what the internet is, but I swear they're there. They probably exist for real. But in the meantime, I'm just going to pet Lilac, and then I'm going to go dance in the background.